Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Welcome back to the Dental Implant Practices podcast, and today I've got a special guest, Dr. Arun Garg, and it's such an honor for me to introduce our guest today. Dr. Garg grew up in Gainesville, Florida, and completed his engineering and then dental degree at the University of Florida. And is that correct?
That's correct, absolutely.
Okay. And then you completed a residency training at the University of Miami Jackson Memorial Hospital. He served as a part-time professor in the Division of Oral Maxillofacial Surgery at the University of Miami School of Medicine.
It was actually full-time professor.
Full-time, okay.
Full-time professor for 18 years.
For 18 years, fantastic. Yeah. And then you left there to pursue a private practice in the Miami area, is that correct?
Exactly.
Okay. And correct me if I'm wrong here, but you have authored 8 textbooks and translated into 7 different languages, and have published hundreds of articles and chapters in other books, and
right.
So you're somewhat of an expert in implant training and implant placement and restorations and surgery techniques. So it's definitely an honor for me to have you on the show and talk about implant dentistry with you.
Great, thank you.
Yeah. So what I'd love to get started with here is, I would love for you to talk to our audience of dentists and general dentists in particular about your training seminar. I know you're heavily involved with your training seminar, your Center for Dental Implants. Tell me how that got started, and the different courses you offer, and the pathways that dentists will take through your seminars.
Sure. As I told you, I was full-time faculty at the University of Miami for a long time, for 18 years. And the way the arrangement was is full-time meant we were not allowed to have a private practice outside the university. So full-time was truly full-time. It was I got to the hospital at 7 a.m. every morning. I left about 8 or 9 o'clock every night, and that was Monday through Saturday. And so it was 14-hour days, 6 days a week. You do the math on it, about 70, 80 hours a week is there. And we weren't allowed to have private practice, and nor was there any time to do that in any case. And there was the private hospital, University of Miami Hospital, where we operated and charged normal fees. And there was the Jackson Memorial Hospital, and there we operated. Patients got things for free. And so on the Jackson Hospital side, we can invent new techniques and try new techniques and such. And then once we developed the technique, we could then lecture about it and present it and write books and articles about it. And of course, incorporate it on our patients or at the University of Miami side of things. And so it was a nice environment. It gave the best of both worlds. In essence, there was a private practice through the university. The university got all the money. I was on a fixed salary of $42,000 a year. And you do the math on $42,000 a year divided by 70, 80 hours a week. So it was probably below minimum wage. But it didn't matter. It was very exciting because there was the other side, the Jackson Memorial Hospital side, which private practice just doesn't allow, is where we could try out new things multiple times. The patients weren't paying. They would sign consent forms. We're trying out experimental procedures, and gave us a chance, like I said, to write articles and books and lecture about these kinds of things. And so I did that for the 18 years. I left there. In that time, companies, when they had a new product, they had a new device, a new CAT scanner, a new laser, whatever it was, they would come to us at the university and ask us to test it for them, publish articles for them. They would give us things for free, ask us to do articles and publications after we tested it on our Jackson patients. When the economy started contracting, companies no longer provided this latest, greatest things to me. And I enjoyed being on the cutting edge. I wanted the newest stuff. And all of a sudden, I realized that I could do that better from a private practice perspective. I could go in a private practice and thereby buy the latest things and then try them out because companies just weren't donating to the university anymore. And so I went into private practice, and I was able to do that side of it is new things. I was able to do the private practice side because I had a private practice and have a private practice. The training side was I was at the hospital training residents is full time. So that I started as seminars. And there at the hospital, I was used to long-term training, not just a 1 day or 1 hour, 4-day course. So we started a whole series of courses. And the first one we called the Continuum, because the Continuum, it's now it's down to 4 weekends. It actually started with more, but it's down. We've got it very, very lean now. 4 weekends, 8 full days. That's lectures and hands-on workshops on pig jaws and cadavers and such. And that's kind of entry point for folks that have done 0 implants or 20 implants or 50 implants or less than 100 implants. That's sort of the entry-level program for them. Is then what happens is folks say, well, that was nice, but I want to do this on patients. If you don't want to do it on patients, then we can do procedures on patients. For that, we built a dedicated facility in Dominican Republic. It's 26 dental chairs, all shipped from America, with compressors shipped from here, vacuums shipped from here, fully air conditioned and such. CAT scanners and lasers and CEREC machines is all there, brand new. And we take folks down there who then have the opportunity to do on patients the same things that we talked about in the class and did on pig jaws and dental cadavers under faculty supervision, one faculty member supervising every 2 chairs. So very, very intense supervision. So those are the 2 core programs that we've got. And then we've got a smattering of other programs.
Gotcha. Is that second program called your Master's Series? Is that what you're referring to?
No, that second one actually is called Live Patient.
Oh, Live Patient. Okay, yeah.
Yeah, it doesn't have a fancy name to it. The
Sure.
Master's Series is sort of a second-level continuum.
Gotcha.
Level 2. So the continuum covers things like socket preservations, treatment planning patients, placement of implants and what anesthetics to use, what medications to use, what kind of drill motors and drill speeds to use, what kind of soft tissue designs and flat designs to use, those types of things. What's called a Master's Series, sort of the second-level continuum, that's also 4 weekends, also 8 days. That's a full day on ridge splits and ridge expansion. A full day on PRP, PRF, CGF growth factors. A full day on lateral wall sinus lift. A full day on crestal sinus lift. A full day on chin blocks and ramus blocks and cadaver blocks. Is a few hours on nasal lift. Is a half a day on immediate extraction, immediate implant placement. A half a day on guided surgery. Is a half a day on titanium mesh. Is so these types of things. So that's what that is. And then a lot of folks then choose to come back to Dominican Republic for a second time to do these more advanced procedures under my and the other faculty supervision.
Excellent, excellent. So you've got an entry point for someone who's never placed. You've got a maybe a hands-on course for people who have placed and want to take it to the next level. And then you've got a master's course for people who really want to take it to the next stage and say, okay, if we need to create bone, or if we need to.
Those are guys that have probably placed over 100 implants already, either through our courses or through other courses.
Sure.
And really want to take the next level. Yeah.
Sure. Yeah. Excellent. And those all sound like great places. So you've got someone who's you can pick up them at any level in their implant training and have something to offer for them.
Yes, absolutely.
Yeah, great. Now so let's just go back to your Continuum course here a moment, just to touch on that. You said that's four weekends a year. I know you've got those all over the country. Who's on your teaching team with that, or are you flying all over the country all the time?
I know it sounds shocking, but I do every single one of those days myself.
Wow, that is.
When it's that Continuum, it's 4 weekends, 8 days, 8 hours per day. I personally do all 64 hours of the didactic material there. The Master Series, it's 4 sessions, 8 hours per day, 8 days, all 64 hours of it I do myself. Okay.
That is dedication right there, I must say.
Live patient programs in Dominican Republic is 3 days of surgeries under my supervision. When a doctor goes down, him and his partner, between the two of them, they place a minimum of 40 implants. And when they go down for sinus lift, between the doctor and his partner, they do a minimum of 30 lateral wall sinus lifts. I'm there for every single one of those the entire 3 days.
Wow. Now, is the are sinus lifts included in that live patient seminar? If someone says I've placed a couple hundred implants and I want to look into sinus lifts and some basic bone grafting, is that included in your live training dental implant?
Absolutely, of course. Yeah, they could go down and focus on lateral wall. And like I said, between them and their partner, they would probably do about 30 lateral wall sinus lifts over 3 days under supervision. They could focus on chin blocks or ramus blocks, or cadaver blocks or ridge splits, or they could say, let me do a little bit of each. I don't want to focus on any one thing in particular.
Yeah, no, I know myself. I've placed hundreds of implants myself, but the sinus lifts and the ridge splits would definitely be something I want more training on. And part of the problem is I just haven't known where to go for that and what to get, because that's not something you just read in a textbook and feel comfortable doing.
Well, that's the problem with almost all of these things, is what happens is, other than dental school or formal residency, there's no opportunity to do live patients.
Absolutely.
And for formal residency means shut down your practice for 3 to 4 years and go do a full-time residency. And from textbooks or from videos or from YouTube or on pig jaws and such is, one can kind of maybe pick up implants, but to pick up a sinus, the pig jaw doesn't have a sinus. The cow jaw doesn't have a sinus. On a cadaver, it's one sinus on a cadaver, and it's very, very expensive to do more than that.
Sure.
And so the only way to really learn this on live patients, and no one's built that model before, is to be able to do live patient without having to go back to a formal full-time residency program.
Yeah. No, I think it's amazing. I think you're right. I would love to go back and go through residency training or even get my oral surgery degree. But, I love general dentistry and I love implants, but some of those aren't practical. I want, high technical degree training, and other dentists do too. And they want that at a place where they've got someone who is able to teach them that and able to teach them that on a live patient. So I really must say you've got a real novelty there. That's a fantastic thing.
What happened over time is folks said, well, can I come down and do extractions for 3 days? And I was a little bit surprised. I'm like, well, I mean, you're a dentist. You need to learn extraction and socket preservations. But you know what? Some people have focused on restorative their entire career and did want to learn extraction and socket preservations. So we started doing that and offering that for 3 days to them. And then other folks said, well, I'm good with extractions, but I want to do third molars. And there's no way you can get that from textbooks and such. So we said, okay, come down and, you do 60 third molars under supervision, impacted third molars, and we'll line up a patient. So we started doing that. And then others said, I want to do soft tissue, gingival recession procedures, and flappenosities and free gingival grafts. So we started screening patients for just specifically soft tissue. Now, those things, the third molar, the extraction, the soft tissue, I'm not personally there for. It's not my particular passion.
Sure.
I have phenomenal team members that train on that. I've got a U.S. trained DDS, MD, Maxillofacial / head neck surgeon that's there for the extraction and or the third molar course. I've got a faculty of a perio program that's there for the soft tissue program. But essentially, we've expanded into these things and could handle almost anything someone wanted. It's just a matter of screening the patients and getting the right faculty members for it.
Sure. Now, so let's say someone like myself said, "Hey, I'm all aboard. What do I need to do this? What kind of time frames are we looking at? What kind of costs are we looking at? How often do you have these programs going on? Kind of walk me through that scenario."
They go on all the time because we built a dedicated facility.
Okay,
and
great.
So it's like it's once a year. It's about every 2 months. Okay, and so about every 8 weeks. It takes a little longer to get in because they do get filled up. And, a lot of times when one gets this e-brochure that says, well, limited attendance, well, when it's a lecture course in a hotel, it's not really limited attendance because they can always get a bigger room.
Sure. Yeah.
And, that's just sort of marketing hype when it says limited attendance in most cases.
Yeah.
In this case, because it is dental chairs and because it is motors, it is truly limited attendance. And it truly does fill up and you truly have to wait. And so we do them about every 2 months, but the wait list is about 6 months.
Okay.
So it keeps sold out about 3 sessions in advance. Okay.
Gotcha.
And then is the programs You asked about pricing and such.
Sure.
We based it on what my cost is. So, for example, the extraction program. The extraction program is it's extractions. I mean, it's forceps, which are reusable, and some graft material. And so I got to cover the graft material. And when you're doing that many extractions, you probably use about $2,000 of graft material, a little bit of sutures, a little bit of lidocaine. So that's about $2,500. Okay, to cover the graft material, to cover the sutures, cover the lidocaine. Okay, is the third molar is similar. Okay, the soft tissue is similar. The implant is higher because if I give you a bag of 20 implants and they're roughly $150, $200 each, that becomes $3,000 to $4,000 of implants you're given.
Sure.
At a burrs for every single is not for every single case, but every single trip down there. And so the burrs cost is the graft materials cost. And so the cost, when you start adding these things up, it becomes $13,000.
Okay.
So depending on which program it is, it's from about $2,500 to about $13,000. And I'm very transparent about the cost. I mean, you can sit there and list through exactly line item what it is.
Oh, sure.
Yeah.
Well, and these types of procedures aren't cheap, and I think everybody understands that. But I think it sounds like the type of training you're going to get is invaluable. Once you come back from that. So I think, you can spend $10,000 on a weekend course where you just sit there and don't touch a burr.
Oh, absolutely, absolutely. And that's why when you see the reviews on it, when folks talk about this, it's always words like not great course, amazing course, but more like life-changing. That's kind of what we hear over and over is when folks finish.
Yeah, that's fantastic. So I know, I did some reading on your Implant Seminars website. You talk about, you're giving your course books away too when you sign up. So talk about your course books that you've written over the years, and what kind of books do you have available if somebody hasn't heard of your books or doesn't know of you, and what are the topics of those?
Well, the very first one was when I first started doing this. When I first started doing my courses, it had notes, and they were in a notebook. And Elsevier Publishing approached us and said, "Hey, can we publish those notes as a book?" And I said, "Okay, sure." We'll merge those, of course, with my slides. So we took my slides and the notes we were handing out in class, and they merged it together, and they were just called Practical Implant Dentistry. So about a 300-page book with about 500 pictures in it. And so it was all my lecture material and all my slides in essence. And then they came back a few years later and said, well, we'd like an updated version. So now there's a Practical Implant Dentistry second edition. And now in about a year or two, they'll be coming out with a third edition of that. So that's the core book and the first kind of book that I came out with. And then my passion is bone grafts, as you know, is sinuses, ridge splits and such. So then I did a book with Quintessence Publishing, and the title is literally Bone.
Sure.
Bone, Biology, Harvesting, and Grafting for Dental Implants. That one is about 380 pages, about 800 color pictures in it. And so that was the next book we came out with. The next one was a joint book between myself and is Robert Marks. And that was on growth factors, dental and craniofacial applications of platelet-rich plasma.
Okay.
And then I started saying, well, these are books based on my passion. And then we started basing books on people's request. In my courses, what would happen is sometimes folks ask, what exactly is PRP? What exactly is this? What exactly is that? And
sure.
There's a whole vocabulary here. And so I put together a dental implantology dictionary. So when they're in the course, of course, they can simply ask me. But when they're reading in the evenings or after they finish course, we put together a dental implantology dictionary. For soft tissue management, folks said there's not good books on soft tissue for implants. There's a lot of great books on soft tissue for teeth, just on the implants. And so I took my cases on that, and we put together a book on soft tissue around dental implants. Then folks, I just noticed, because as I went into private practice, I was very sheltered at the university, and we had a lot of patient volume. When I went into private practice, it was tough. It was tough growing the practice. It was tough getting the patients. It was, all of those kind of things I never thought about when I was at the university. And so I trained myself, and I worked through a lot of things. And I thought, wow, I can't be the first guy struggling with how to grow a practice. So I took all the information I put together for myself once I went to private practice and said, let me make it easier for my alumni or anyone else to not have to go through all the trials and tribulations I went to. And I did some things right. I did a lot of things wrong. And but finally, things started going nicely after lots of struggles. So we put together a book on that, Implant Excellence, 5 key steps and all the sub-key steps to grow the practice.
Sure.
And then other books, things that really more for patients, patient post-operative instruction, because normally most of us give a one-sheet piece of paper on post-op instructions after surgery. And they've got a lot of questions. What can I eat? So we put together some menus in there, what they can eat in the first 24 hours, what they can eat in the second 24 hours, what they can eat after a week. Should I take vitamins? We put sections in there on vitamins. What kind of exercises can I do? So I put sections on exercises. So then a nice glossy 100-page patient education book. It's great information for them. And also it just works out marketing-wise because it sets our practice apart from other practices that's just given a zero stuff, one-sheet post-op instructions.
Sure.
And then we make that available to anybody that wants those booklets as well. And so that's where the first set was just my passion, and the second set became wherever I saw a need for dentists that I came across. And so I started putting together these books for them. Writing books is sort of a passion of mine. It comes very easily and naturally to me. And so I put those together.
Well, that's fantastic. Yeah, I've got a couple of your books, and I think it's amazing that you were just able to throw your slides and thoughts together and come up with this fantastic book. I myself am not a very good writer, so it would take years and years and years just to get something basic. But
Well, everyone's different like that. Very naturally to me, so I was able to do it. On the other hand, you and I talked right before we started this podcast. I was like bewildered about how to do a podcast, and here you are doing it on a regular basis.
Sure,
we've all got sort of our strengths and weaknesses, and we focus on those.
Yeah, well, that's fantastic. So, other than your coaching and lecturing, are you involved with many of the academies these days? Obviously, there's a lot of implant academies out there. Are you familiar with most of the big ones, or have any association there?
I am, and I was always members of all of them. I still am. I was involved in a much larger extent before I left the university. While I was at the university, I was a member, of course, of the American Academy of Implant Dentistry, ICOI, AO, even AIIP, some of the smaller implant associations and academies. And with ICOI, I went to the highest level. I was their international treasurer for 2 years, then secretary for 2 years, and vice president for 2 years, and then the president of the entire association for 2 years. And during that 8 years, we grew the association from 2,000 members up to 10,000 members. Obviously not myself. There's a whole lot of people that did that. But
sure.
So I was very, very involved. I was program chairman for about 8 of these national symposiums that ICOI had. I organized some of the local things for some of the other associations. Now I'm really not involved with the association, other than my membership. I pay my membership dues. I get the journals and such, and that's about the extent of my involvement with the associations.
What would you say as a general dentist wanting to get more involved with implant dentistry? What are 1 or 2 good associations you would recommend for them?
I think any of them. I really don't have a strong bias is for or against any of them. There's lots of good associations out there.
Sure. Now, I heard you talk about cone beam in 3D. Tell me how you're incorporating 3D cone beam into your practice and into your training.
For cone beam I use it. I grew up in an era where we didn't have it routinely. So early on, we did all kinds of procedures, all our block grafts and all the chin blocks and all the, sinus lifts are all done routinely off of just Panorexes. That's the era I, kind of cut my teeth in.
Sure.
But in the 10 years, when I opened my practice 8 years ago, when I left the university, I got a cone beam there as soon as I opened it because I wanted cutting edge things, and I was cutting edge, and I was building a new practice. Now I've got 3 practices in Miami, and as I built the second practice and third practice, I put cone beams in them. When I built the clinic, the 26-chair clinic in Dominican Republic, of course, I wanted that state-of-the-art. So I have a cone beam there. So I went from a guy who was using only Panorexes to a guy that actually personally owns 4 CT scanners, cone beam, between the different practices.
Mm-hmm.
And so I use them, and I use them to routinely. I look at the patients. I still use Panorexes because for me, is a patient comes in, I put them on a Panorex setting. I get a quick look because I can read the Panorex quickly. 30 seconds, 40 seconds is a quick cursory review, and then we start talking. And if the person is truly interested, then I get the cone beam, and then I spend the 15 minutes or so to really look at that cone beam and analyze it in detail before coming up with a definitive treatment plan. New patient comes in, I get the Panorex. It turns out they're really not interested, okay, and then I don't spend the 15 minutes it would take to study and analyze the cone beam. I look at the Panorex, talk to them, is a general discussion of what their needs and desires and wants and such are for things we can provide. And if it's not a good mesh, then that's it. So I don't jump right to a cone beam and spend a lot of time analyzing it. I use the Panorex, and then for those folks that are interested, I routinely get a CT scan on them.
Yeah, I think that's a great blend of technology because, like you, I was trained on a Panorex, and I still use that as my first screening protocol. And then, check if the bone's there, check out the level of interest, put a basic treatment plan together. And if there's further interest to explore implants and we're moving forward, then we take the cone beam, study and analyze it, and really get our game plan together. But
perfect.
Are you using that for are you using that for surgical guides at all? Obviously, you've got quite an experience. Are you what's your level of use and experience with surgical guides, and how are you using those in your private practice?
I use guides, and I started with guides from the various companies out there, Anatomage and Materialise and such. Mm-hmm. And then I got steric machines in my clinics here and down there, so I started making the steric guides as well. So I do all of them because number one, I like doing all of them, and number two is as a speaker, I need to be conversant in all the different modalities and not just be conversant in one. So I use all the different modalities for guides. And what I do is all tough cases I use guides on. So what I would say a tough case would be upper anterior aesthetic zone because I want to nail that. That's got to be perfect. Okay, so I always use a guide on. All really straightforward cases, I'd probably say I rarely use a guide on. 2 implant overdenture. It's almost more hassle for me to design the guide, make the guide, use the guide, because if I make it bone-borne, I've got to make a huge flap for those 2 implants.
Sure.
If I make it bone, it's moving around, I can't see the bone. For me, it's much easier. Make a small, relatively conservative flap, look at the bone, put in the 2 implants, I'm done with it. So for those straightforward, easy cases, I don't almost never use a computer-generated guide. For the tough cases, anterior aesthetics is above the lower premolars, close to metal frame, I routinely use computer guides. And the cases that are in between them, I use a judgment call. Is on some of them, I'll say, you know what, I think I want to lean towards a computer guide on this. It'll make things faster and more accurate for me. On this one, I think I can actually use a better job. It's a little tougher for me to see exactly the thickness of that bone there, or I'm going to be doing a ridge split. And so, the guide would really only serve as a pilot hole for me to mark the dot. So, you know what, I can do that with other ways other than the computer guide to mark the pilot hole. I'm going to do a ridge split and median placement. So kind of the medium cases, I do case by case.
Sure. And I think that's a great use for guides because you've got a lot of experience without guides. So you're not mandatory on them to do, but you understand that when there's cases of minimal error involved, that sometimes that could help you place better precision and have minimal risk. So I think that's a great balance. Yeah.
Absolutely. Like I say, upper anteriors, for example, it's got to be dead on. You're doing a single tooth number 8, and you need 3 millers from each tooth, and instead you end up 4 from one side and 2 from the other side. That's not going to work. Mm-hmm. Is above the mental frame, and you've got to be exact.
Yeah. Well, I think that's great. That's a great balance, and I think good advice for everyone to hear there. So, when it comes to to implant dentistry, there's a lot of paths you could take. What would you recommend a good entry place for someone who's interested in just further advancing their skills? If someone says, "Look, I've never placed any implants," tell someone what you think a good path for them would be.
I mean, at the risk of sounding biased, but I would say our continuum level course is it's this is what I do. I'm a professional educator.
Sure.
I didn't go in and say, well, I'm a guy in private practice and I would like to do a course or two on the weekend because for ego gratification, or to say, hey, I'd like to do a course or two on the weekend and make some extra money. That's not who I am. I've dedicated my entire life and my whole career to education. That's why I worked for $42,000 a year for 18 years. That's why, as you know, for writing, it's over 150 published articles. I don't get paid. There's $0 you get paid for publishing an article.
Sure.
There's $0 you get paid for book chapters and about the 20 or so book chapters I've written other people's books. On the textbooks, I did get paid. I get 10% royalties on textbooks. But book chapters of other people's books, nothing. They're the ones the editor gets the 10%. The 150 scientific articles, $0. And I did it because of a passion for education. And what's happened is not just a passion, is over the time and is such we've developed systematic methods to get people trained. They will do these things. It is not about me standing there saying, hey, look, isn't this slide great? Here's the before and after. Aren't I awesome? No, it's about getting them trained to implement this stuff as a part of everyday general dentistry. You go to operatory 1, you do a bridge prep. You go to operatory 2, you stick in a couple of implants, go back to operatory 1, do a root canal, go back to operatory 2, do a bridge, go back to operatory 1, do another implant, go back to operatory 2, do a quad and a fillings. That's the way it should be. Yeah.
And so after your continuum, that takes about a year. Is that correct?
Well, since it's 4 sessions, we space them about a month apart.
Okay.
So sometimes they might be 2 months apart. So it's really more like half a year.
Okay.
Depending on how we spaced it. Yeah.
So
sometimes we have to work on holidays and such. So it's about every month, but sometimes working on holidays, it may turn out a little bit more. So it would finish up between 4 to 6 weeks.
Okay.
And we keep the curriculum the same in all the cities.
Yeah.
So if someone missed a session, they could easily make it up in another city. If they wanted to get through it faster, they could do different sessions in different cities. Or if they want to go at a slower pace, they could do different sessions in different cities. But if they're going to go in the same city, typically it's going to be over 4 to 6 months. And then those that choose to or want to or need to do the live patient program, then go on the live patient program. And that's it.
Yeah.
In the continuum and or the live patient program, that's it. They're going to be doing probably 60% of cases, 70% of cases that walk in their office.
Yeah. And I think that's all a lot of dentists want to do. I don't know that a lot of them have, the love to go further, but I think, they may say, look, I want to handle all the classic simple cases. And I still want to have a good relationship with my oral surgeon or periodontist. I may send those 40% to them, and that's great. But I think,
exactly,
like you're saying,
that's what I told you. When I told you the continuum's now down to 4 sessions, it used to not be 4 sessions. It used to be 8 and 10 sessions because level 1 and level 2 were all together. It was all crammed together. And so it was a full year back then. And back then when I first started it, it was marketed and the participants are all oral maxillofacial surgeons.
Sure.
And then after about 5 years, we got oral surgeons trained in the country that wanted training. And then it was marketed and it was all periodontists. Mm-hmm. And for that group, all of them wanted to go on into the sinuses and ridges, and so it was 10 weekends. And then once we trained all of them, we started focusing on general dentists, and we realized very quickly is that a lot of general dentists didn't want that second half. So we said, okay, let's just divide it into 2 separate programs. The ones that want this can focus on this, and the ones that want the other can then take the other separately. And so that's how it evolved. The fewer weekends essentially broken up into 2 separate programs.
Well, I think that's fantastic. It sounds like there's a lot of flexibility, and the course is laid out in a way that makes sense for the progression of that learning. So someone could take half a year and do your your continuum, and then take the other half of the year and focus on the hands-on and have a really intense 1 year kind of mastered program of implantology without having to take off, from their private practice.
Right.
Yeah. And then there's still more room to grow on top of that, when or if they choose to. So I think, you've kicked through a lot of, barriers and kicked down a lot of doors for these people looking for top level training. And I think that's fantastic.
Thank you. Thank you.
Yeah. Now, I've got a couple more questions for you, then we'll wrap it up. I know I'm catching you off work hours, and I appreciate you taking our call.
No, it's a pleasure.
Yeah. What do you see it are your three best practices in implant dentistry? I know that's a vague question, but if you had to narrow down to three of your kind of most important things that you use in your private practice on a daily basis, whether it's a technique or a tool or a philosophy, what kind of main things do you always keep in the back of your mind, or tricks do you have?
Oh, I don't know. It is kind of a vague question. Let me just start tossing out a couple of things, and you can guide me if I'm on the right track or not.
Okay.
Okay. Is that okay? I would, again, I don't know if I'm on the right track or not, but use of corticosteroids after any kind of surgery is something like Decadron, also called dexamethasone. I give them anywhere from about 4 to 8 milligrams. Is injected intramuscular, right into the intraorally in the flap, depending on the extent of the surgery, and so it does wonders for surgery. The other thing is the concentrated platelets. The whole list of names: PRP, PRF, CGF, whatever they want to call it. But basically, fundamentally, taking test tube blood, spinning it, and getting the middle layer, whoever's centrifuge du jour or whoever's test tube du jour is your favorite and you want to give credit to. But basically, the middle layer is the decrease in inflammation from that, is a decrease in post-op pain, improved healing is from that. So the Decadron I would use almost routinely. Is things like PRP is almost routinely. And then things like the appropriate anesthesia. Is instead of just always in general dentistry, typically just using the lidocaine 2% with 100,000 epinephrine, is sometimes using articaine, is sometimes using is just carbocaine if it's quick is a procedure. Sometimes using longer lasting anesthetics is so using the right anesthetic. And these days really is routinely what I do is I buffer the anesthesia. It really does make it truly makes it take effect not in a typical 5 minutes that we're used to or so for anesthesia to take effect. It's 30 seconds later I can start cutting with buffered anesthesia. So I save that time. Is for me it's actually more profound anesthesia. It's painless for them going in is because the pH is neutral for them. So those are probably 3 quick tricks.
Yeah, no, those are fantastic. I don't have much experience with the platelets, but the corticosteroids I think is an interesting topic because I'm not sure how many implantologists practicing out there are doing that, and I think that's fantastic.
Right.
Yeah, the anesthesia is a big one. I think the use of articaine obviously has significantly improved our profoundness with that. So I think that's great. And are you teaching any of the platelet spinning and placing at the courses?
Yeah, all the time. In fact, that's one of the things we have a 1-day separate program on. And we've got a 1-day separate program for doctors that talks about the biology and how to draw the blood and venipuncture. We've got a half-a-day program for dental assistants where we go through training them on venipuncture, on how to draw blood and how to make the PRP, because they're the ones that are ultimately going to implement in the office. And so, and that program has become so popular. The one for assistants, we do that program every 2 weeks. That's done 26 times a year is on assistants. So we're training assistants from all over the country on how to draw the blood and make the PRP, and they love it, and the doctors love it.
Oh, that's fantastic. I didn't realize you were training assistants. So is that at the surgical courses? Do you recommend doctors bringing their assistants, or is that a separate program? Courses. Is it?
And I do that all over the country. That's in Miami and New York and DC, Chicago, because a lot of times doctors don't want to fly their assistants out of the country or even to Miami. So we bring it around the country. So that half-day program is done all over the country, is like I say, 26 times a year. And each time there's a group of about 20, 25 5 assistants, and my assistants and my nurses is run that. I step in and do a little biology section on it, but they run that, and is 95% nurses or the 95% assistants. They go back and implement it in the general practice, and they love it. Can you imagine? It's a big break from scrubbing instruments and setting up rooms and breaking down rooms. It's really very empowering for them and makes them really feel good about doing this. And for the doctor, it means then it doesn't take up any doctor time. He tells them, get the PRP ready. And so she draws the blood. She calls the doctor. Okay, doctor, go ahead and numb up the patient. The doctor numbs up the patient. Starts the surgery. 12 minutes later, she's made the PRP for him. He's never going to be waiting because there's no surgery he does faster than 12 minutes. So he's never waiting for the PRP. And the PRP is good for 4 hours. On the other hand, it's never going to be over 4 hours that it's not really as good or effective anymore. So the timing works out perfect for him.
Yeah, that's amazing. Yeah, that really is. So all of the information for your seminars is on your webpage there, implantseminars.com. Is that right?
Yes, implantseminars.com, exactly.
Yeah, and that's the best resource you think for anybody looking to get on your courses and do that. Just get on there and contact you that way. Is that correct?
Absolutely.
Excellent.
Make it very easy.
Yeah.
They get on. They can call in, talk to me, or talk to any of the team members, or email or text anyone of us.
Well, I am very excited to get going with this. I think from our conversation today, I think you just convinced me to take your live patient course. So hopefully you'll be seeing me down there. And I'm in the process of building my new practice right now, and so we're moving at the end of this year. But I think early 2017, you're going to have me down there. So I'm going to be looking forward to seeing you there.
Fantastic.
Appreciate your time today, and when we get further along, maybe looking forward to having you back another time, okay?
That would be fantastic. Okay.
Thank you so much.